Peritonitis. Tissue is a cellular organizational level intermediate between cells and a complete organ. A tissue is an ensemble of similar cells from the same origin that together carry out a specific function. Organs are then formed by the functional grouping together of multiple tissues. Peritoneum is a thin layer of tissue covering the inside of your abdomen and most of its organs. Peritonitis is defined as an inflammation of the serosal membrane that lines the abdominal cavity and the organs contained therein. The peritoneum, which is an otherwise sterile environment, reacts to various pathologic stimuli with a fairly uniform inflammatory response. The three main types of peritonitis are primary spontaneous peritonitis, an infection that develops in the peritoneum which is seen mostly in patients with chronic liver disease. Secondary peritonitis, which usually develops when an injury or infection in the abdominal cavity allows infectious organism into the peritoneum. The most common form of peritonitis encountered in clinical practice. And tertiary peritonitis often develops in the absence of the original visceral organ pathology. Infection of the peritoneum is divided into generalized, known as peritonitis, localized, known as intra-abdominal abscess. Causative organisms: pyogenic bacteria, E. coli, aerobic and anaerobic streptococci, staphylococci. SBP is the most frequent bacterial infection in cirrhosis, accounting for 10 to 30% of all reported bacterial infection in hospitalized patients. In outpatient without symptoms, the prevalence is low, 3.5% or lower, but the prevalence increases in the nosocomial settings, ranging from 8% to 36%. The risk factors are chemicals, irradiation, foreign body injury, microorganisms, appendicitis, pancreatitis, peritoneal dialysis, injury caused by an operation. Signs and symptoms of peritonitis are fatigue, abdominal pain or tenderness, inability to pass stool or gas, fever, loss of appetite, nausea and vomiting, thirst, low urine output, cloudy dialysis fluid. Investigation: perform a physical exam, then test to confirm a diagnosis. Blood test: a sample of your blood may be drawn and sent to a lab to check for a high white blood cell count. Imaging tests include X-ray, ultrasound, CT scan. Peritoneal fluid analysis: using a thin needle and take a sample of the fluid from peritoneum. Examination of the fluid may show an increase in white blood cells. Treatment: if the patient diagnosed with peritonitis, he or she will be admitted to the hospital. The patient should immediately start receiving intravenous antibiotic or antifungal medication to treat the infection. Treatments may include intravenous fluids or drug to maintain blood. If the patient has peritoneal dialysis-associated peritonitis, he or she may receive medications that are injected directly into the peritoneal tissue. Until the peritonitis is cured, the patient will need to use another method of dialysis, such as hemodialysis. In many cases, emergency surgery is required, especially if the peritonitis has been caused by conditions such as appendicitis, a perforated stomach ulcer, or diverticulitis. Infected tissue such as the burst appendix or abscess will be surgically removed. So will any part of the peritoneal tissue that has been seriously damaged by infection. During hospitalization, the patient should be closely monitored for signs of sepsis and septic shock, which usually requires immediate transfer to an intensive care. Antibiotic medication include cephalosporin plus metronidazole or gentamicin plus metronidazole or gentamicin plus clindamycin or piperacillin with tazobactam alone. Peritoneal dialysis associated: vancomycin plus ceftazidime added to dialysis fluid, or vancomycin added to dialysis fluid plus ciprofloxacin by mouth. Follow-up: temperature will return to near normal. Vital signs should stabilize. Patients should not appear in distress with an exception of recognized discomfort and pain from incision drains and nasogastric tubes. At 24 to 48 hours, if a suspected pathogen is not sensitive to an antimicrobial agent being given, the patient has not shown sufficient improvement, the regimen should be changed. If the isolated pathogen is extremely sensitive to one antimicrobial and the patient is progressing well, concurrent antimicrobial therapy may be often discontinued. Treatment regimen can be judged as successful if the patient recovers from the infection without recurrent peritonitis or intra-abdominal abscess and without the need for additional antimicrobial. Unsuccessful if a significant adverse drug reaction occurs, if reoperation is necessary, or if patient improvement is delayed beyond 1 or 2 weeks. Superinfection may occur. It is often due to Enterococci, Candida, Pseudomonas, and Serratia.